Good afternoon. A warm welcome from Cincinnati Children's Hospital Medical Center. I'm Tina Chang, Chair of the Department of Pediatrics at the University of Cincinnati, Director of our Cincinnati Children's Research Foundation, and Chief Medical Officer, and I'm honored to be the moderator today. We are celebrating the 100th anniversary of our B.K. Ratchford Department of Pediatrics, which has provided healthcare for legions of children, educated the next generation of child health professionals, and made landmark research and quality improvement discoveries with global impact. Cincinnati Children's looks forward to the next century in this Envisioning Our Future for Children seminar series. A few logistics before we start with our esteemed speaker. First, this webinar will be recorded and will be archived for online viewing in the future. Second, to claim continuing medical education credit, you must complete an evaluation that will be sent via email at the conclusion of this presentation and must be completed in the next 30 days. If you have any questions related to this session, please enter them in the Q&A section of Zoom at the bottom of your screen, and we welcome your questions. We'll try to answer as many as we can. If you have any technical difficulties, please use that Q&A feature. With no further delay, we are thrilled to have our inaugural speaker, Dr. Yong Kim, who will be discussing bending the arc of history for children. What more important topic can there be? Dr. Kim is Vice Chairman and Partner in Global Infrastructure Partners, a fund that invests in infrastructure projects across several sectors around the world. From 2012 to 2019, he served as the 12th president of the World Bank Group. Soon after he assumed that position, the organization established two bold goals to guide its work. One, to end extreme poverty by 2030, and second, to boost shared prosperity, focusing on the bottom 40% of the population in developing countries. A physician and anthropologist, his career has revolved around health, education, and improving the lives of the poorest and most vulnerable. He was born in South Korea to parents who had fled the violence of the Korean War and grew up in Iowa, where his father was a practicing dentist, his mother a philosopher and theologian. He graduated from Brown University, received his MD and PhD in anthropology at Harvard. While at Harvard, he co-founded Partners in Health, a nonprofit medical organization that provides healthcare to poor communities on 4 continents. With Partners in Health, Dr. Kim developed treatment programs for complex deadly diseases such as multi-drug resistant TB and AIDS in the poorest areas of Haiti, Peru, and several other countries. From 2003 to 2005, he served as director of the World Health Organization's HIV/AIDS department and led WHO's 3x5 initiative, the first ever global goal for AIDS treatment, which greatly expanded access to antiretroviral medication in developing countries. His achievements are inspiring. He is passionate about improving health for all, and we really thank him and look forward to his wisdom on bending the arc for children. Dr. Kim.
Thanks very much, Tina. It's great to be with all of you. You know, everyone calls Dr. Chang because she's in such an important position. But I've actually known Tina since she was in high school. I went to school with her older sister for a year and a half at the University of Iowa, and then Tina and I went to school together at Brown. I transferred there in my sophomore year. So it's really great to be with you. I have to say, you know, I know a lot about Cincinnati Children's just because I've been a student of quality improvement in healthcare, and of course, Cincinnati Children's has been just such an important leader in that field. So it's a really wonderful honor for me to be joining all of you, and I look forward to the conversation. I think, Tina, were you going to ask me a few questions, right? Yeah, you're on as you're on mute still.
So yeah, so we did have some questions for you.
Yeah.
So wanted to ask, if you were to predict the future, what's the most impactful change or innovation in science, healthcare, or health systems delivery that will transform how we operate in the next 1 to 2 decades?
Yeah, so this is, it's hard to focus on anything other than the pandemic because the pandemic has changed everything. And so, let me talk a little bit about what I'm seeing on the pandemic. Before I do that, let me just take a step back and address the issue of why this is called bending the arc of history for children. I think some of you got the notice about the Netflix film called Bending the Arc about partners in health. And unfortunately, the work of Partners in Health has never been more relevant in the United States. A big part of what I've been doing in wearing my sort of infectious disease medical hat has been working with states in the United States, from Massachusetts to the city of Newark to even areas in Texas, trying to build a contact tracing program. Now, you'd think, well, the Johns Hopkins University, Tina's former institution, said that the country best prepared to tackle a pandemic like COVID-19 was the United States. And quite to the contrary, we've had more deaths than any other country in the world. And so you'd think that a group like Partners in Health would never have to work in the United States, except maybe, we had an ongoing project. We still do in Navajo Nation and in some of the very poorest areas of the inner cities in the United States. But we had to step up and start working with the state of Massachusetts, the state of Ohio, a little bit with the state of California, with the state of Illinois, because their own public health leaders basically gave up on contact tracing. Very early on in the pandemic, it was sort of acknowledged by too many people that it's too late to do contact tracing. And any of us who've been working in developing countries are so attuned to that kind of language, because just as we said it's too late to do contact tracing in the United States, we heard in so many countries in the developing world, this country is too poor, and just fill in the blank. Too poor, too disorganized, not enough infrastructure for HIV treatment, for drug-resistant TB treatment. We just heard this over and over and over again. And frankly, just couldn't believe the nihilism of the public health core here in the United States. Now, a big part of that was that, we had an administration that was in complete denial, that was not leading the way in terms of testing and all the things that were needed in order to respond to the pandemic. But part of what we saw was that public health leaders kept saying, no, it's too complicated. There's too many cases. There's too much community transmission. And what we kept saying back is, okay, yeah, but at some point, if there are vaccines, at some point, if we reach this mythical herd immunity, the cases will be coming down, and then you'll need to be able to do testing, contact tracing, isolation, and quarantine, so that you can actually get under the pandemic and the virus under control. So you should build it now. The only state that agreed to really build out a full program was Massachusetts. You're in Ohio. We had a lot of talks with Governor DeWine, and I think we're still involved in some advice, but in Ohio, I think the decision was that you would try to build out a contact tracing program, but I don't think it ever reached the level of Massachusetts. Now, when you look at the U.S. response, you get a really good idea about how just unbelievably devastating the pandemic has been. But then I would just add, I was just on a call this morning with Indonesia, and poverty, inequality, so many issues that affect children drastically are getting much, much worse in the developing countries. So bending the arc is this notion that there are so many things that seem inevitable, like you can't treat tuberculosis, drug-resistant tuberculosis in developing countries. You can't treat HIV in the poorest countries in Africa. And we have Partners in Health continued to try to grab the arc and bend it in a way that it didn't look like it was bending. And again, unfortunately, we're now having to do that in the richest country in the world. But if I were to step back and say, okay, so set the pandemic aside for a moment, and then think about what are the issues that are going to have the largest effect on children. One of the ones that I think have to be raised again and again and again is climate change. And so, if any of you are interested in sort of reading a state-of-the-art, easy to digest a book about where we are in climate change, it's Bill Gates's new book. Bill Gates's new book, and I worked very closely with Bill himself when I was at the World Bank Group, Bill and Melinda. And early on in 2012, when I just started at the World Bank, one of the first things that hit me was just how unbelievably devastating the climate change crisis was going to be, how it was going to have a devastating effect, especially on children, something that my 11-year-old son actually reminds me of every day, about that he's going to have to wear gas masks in the future because the environment will be so difficult to navigate when he grows up in the world. But when I first started at the World Bank, I really took on the climate change issue, and we moved a tremendous amount of resources. We were doing almost nothing at the World Bank Group when I started, and now the World Bank is providing, I think now this year, 35 billion in climate change related activities, which makes it by far the largest financer of climate change related activities. But Bill Gates wrote in 2012, he was a little skeptical, and he says so in his book. But now he's come around to understand just how incredibly important it is, and it will be the issue for children. And if we don't get the pandemic under control, if we don't have a fundamental shift in how seriously we take public health issues, the pandemics and climate change are going to be the issues that the children of today face in a relentless way for the rest of their lives. And so, I think that both pandemics and climate change are going to require us to fundamentally rethink how we organize ourselves in the world. Now, Bill is very focused on, Bill Gates is very focused on technology, which is great. I mean, I think technology is really important. I think technology could have a huge impact in tackling climate change. But in terms of pandemics, I think what we've seen is that all of this great optimism about the role of technology in doing things like contact tracing, testing, et cetera. I mean, those things, there have been great technological advances. There have been, the vaccines we have now are just incredible. And it's incredible that we've gotten so many of them in such a short period of time. But for pandemics, I still think that the traditional public health response, testing, contact tracing, isolation, and quarantine, that's very labor intensive, that requires people. I think that's what is still missing. I think public health will grow tremendously. For example, at Brown University, our alma mater, partly because the new dean of Brown has been such a great and clear spokesperson for the health community around COVID, Ashish Jha, the number of applications for the MPH program doubled. And the numbers especially grew in the communities of color. So I think that these are two of the issues that will affect everyone. Now, in terms of innovations in health and healthcare, let me point to two. Look, I've been in meetings and in conversations with folks at Moderna. One of my former students and somebody who worked at Partners in Health along with his wife is now the CEO of Novartis Pharmaceuticals, a really wonderful guy, Vas Narasimhan. And I've been in touch with these folks, and what they've been able to do in developing these mRNA vaccines is really incredible. And so I think that it's going to be possible for us potentially to keep up with the mutations and the variants. This is what Nubar Fayan, who I've been speaking with at Moderna, Nubar seems to think that because they've done so much modeling and that they're they've developed this technology so aggressively that they're going to be able to keep up with the variants. But I think the issue is not going to be, in this case, the technology is not going to be the robustness of the vaccines. It's going to be in delivery. How do you actually deliver? I mean, it's been said over and over again, vaccines are not the answer, vaccinations are. And, what are we seeing? Well, we're seeing a very slow rollout in Italy, and Italy just went on lockdown again. And, there are probably lots of reasons for that. But I think right now, there is not a great strategy out there for how to deliver the vaccines in a way that would enhance their ability to help us bring the pandemic under control. So on the one hand, tremendous development in the health sciences in terms of the development of the vaccine. But I think what we're missing is an equal intensity around figuring out the delivery piece of it. How do we actually get it to everybody? What probably most people know now is that the OECD countries, the rich countries, have already contracted for enough vaccine for 175% of their population, whereas in developing countries, they've only contracted for 25%. And with the way that this virus is moving around the world so rapidly, if you leave huge entire continents, for example, in Africa, unvaccinated, I just think you're going to have to assume that these variants, these mutations, we'll see them coming at us hot and heavy. And so, there has to be a delivery strategy that will really work. So from my perspective, you can't ignore climate change and pandemics for children. It's going to affect their health, their well-being for the rest of their lives. There's fantastic innovations in the health sciences, but I think one of the things that I've been working on, for most of the past decade and a half or so, is to make the point that we now need a new science of delivery. We have to get just as serious about the science of delivery as we are about the basic sciences and the clinical sciences. And Tina, I'll stop this part with just one short story. So one of my most important mentors was a gentleman by the name of Howard Hyatt. Howard was the former dean of the Harvard School of Public Health, somebody I met in my 30s who has been and continues to be a mentor. And Howard's career, he's in his 90s now, still doing great. But Howard started his career in the lab of Francois Jacob, and was on the team that discovered messenger RNA. And so when he returned from his, I think, 2 years in Paris in Jacob's lab, he came back, and he was a physician at Beth Israel Hospital in the United States. And he said, we need to begin doing basic science research at Beth Israel Hospital and Harvard Medical School. We really need to increase the amount of basic science research that we do. And he was told by the leaders at Beth Israel Hospital, Howard, there is no role for basic science research in a teaching hospital in the United States, right? Then after that, he and Lee Goldman, and Lee was the dean of Columbia Medical School for many years. And those of you who know cardiology, remember the Goldman criteria. I think they're still probably being used. And so he and Lee Goldman started a clinical research program in the early 1980s. And it was based at the Harvard School of Public Health. And he went around, because basic science had already been, of course, well established. And he tried to convince heads of departments at the great hospitals in Boston to send some of their residents to study clinical research. And they had started a program on clinical research that was linked between Brigham and Women's Hospital and the School of Public Health. And Howard told me that in the late 70s, early 80s, when he talked to department chairs, they said, Howard, there is just no way that I will send any of our residents to learn clinical research. There's no future in clinical research. Everyone has to focus on basic science. And those of you who are old enough will remember that period. And then Howard was a mentor not only to me, but also to Don Berwick. And when Don Berwick tried to bring quality improvement science, a focus on delivery to the Harvard School of Public Health, Howard once again was told, Howard, everyone's focused on either basic science or clinical research. There's no role for delivery or improvement science. Those are not even sciences, right? So my one mentor has gone through these different stages where he was told that things could never happen. And in fact, he was involved in making those things happen. I think the time right now is to get very serious about the science of delivery and how we can deliver those tools more effectively. And again, I know that in Cincinnati, you guys have really led this charge, which is going to be so important going forward.
That's a great story. So going back to COVID, and it's kind of amazing that our 100 years is capped off with a big pandemic. What do you see have been the most important lessons that we've learned and that can be applied globally to improve the health of children and families?
Well, unfortunately, Tina, I think that we continue to not learn the most critical lessons. I think that most of the world is still completely mired in magical thinking. If you look around and say, okay, so where has the virus been brought under control? And it's only been brought under control in the countries that have been able to put together an aggressive public health response. If you talk to the Chinese, if you talk to the Koreans, if you talk to the New Zealanders or the Australians, they know where every infection has come from, right? When there are any community infections, they go nuts to try to get on top of them. Whereas, in the United States, we remove mask mandates when there's just so much evidence that something as simple as wearing a mask can so dramatically cut down the number of cases and the number of deaths. So I think we haven't learned the lessons, but I think the lessons are pretty clear. I think, you've got to get to a point where you're chasing down every single viral infection, where you know where every single infection has come from. And if not now, you've got to prepare for that once something happens that will allow us to be able to chase down those cases. In Massachusetts, we trained more than 2,000 contact tracers. And what's happened is that when the cases go up, we bring more of them in. When the cases go down, we reduce the workforce. And now the workforce is potentially going to be increased to help with vaccination efforts. Why would you do that? Well, what we found in country after country after country is that people generally don't trust experts. They, in community after community, except maybe for the most well-to-do, they don't trust experts because experts usually come from those very well-to-do communities, but they trust their neighbors. And so we found that if you really want to make something work, a program work, you have to bring people from the community into the workforce, and in this case, the public health workforce. So we're trying to do that in some states. We're trying to do that in some cities. It would be great to be able to do it in Cincinnati. But I think that the problem is that we're still mired in this notion that once we get the vaccines and once we roll them out, everything will be fine. And I think it gets worse than that. I think it's worse than that in the sense that as the wealthy, get their vaccine shots, I think they feel like, well, the pandemic is over for me. And so I'm not going to pay any attention to it anymore. I'm going to go out to my business, want to get things going. But I'll say right now, I think it would be great if we get to 70 to 80%, or whatever. Tony Fauci. Tony, I've worked on every single one of these pandemics. I've been in touch with him throughout this pandemic. I've worked on 5 different pandemics with Tony. Tony says, sometimes he says 80, sometimes he says 90%. Now he's saying that, things could get normal by the end of 2021. But Tony, like everyone else, I think just doesn't know. I think we don't know because we just don't know what the variants are going to look like. But I would say that the people who think that once we get to 70 to 80%, it will magically go away. There's another person who said it would magically go away. And, he was wrong. And there are just too many people who have fought pandemics who tell me things like, well, there may be nothing magical about getting to 70 to 80%. Bill Foege, again, former head of CDC and my mentor, and the one who was really designed the smallpox eradication plan, said over and over and over again during the smallpox eradication campaign, he was told that once we get to 70, 80%, the virus will go away. And he said it never happened. It just didn't happen. There were states that had 70 to 80%, 90% vaccination that still had outbreaks. And there were states that had 7% vaccination and had no outbreaks. What he essentially said was this notion of herd immunity at 70 to 80% is a distraction. You still have to chase down the virus. So, Tina, unfortunately, I think we haven't learned the lessons. I think that we're still guilty of tons of magical thinking. The Chinese economy is almost completely back to normal. They're going to use their vaccines very strategically and use it to go to the places where they suspect where something breaks out. You can bet that the people around that outbreak are going to be vaccinated very aggressively, regardless of their demographics. Other countries that do that are going to get back to pretty much normal, but they're not going to get completely back to normal because the rest of the global economy is going to be shut down. I'm worried. I'm extremely worried right now. I think the Italy going back into lockdown is a very, very serious concern, and it could be so much better. So I have faith in the people who President Biden has appointed. Tony is back in the same tone. Tony is fantastic. Rochelle Walensky is a tremendously skilled and brilliant infectious disease doctor. I think she'll make a big difference at CDC. But the lesson that's not yet learned is that you've got to have a ground game. You've got to be able to chase down the infections. And this is every country in the world. You've got to build the ground game.
Thoughts on how to convince the non-believers and the people that have questioned science in the approach to this pandemic, and how do we get beyond that?
I think the best way to do it is to get people who are from their community, who can explain to them in a way that makes sense to them in their own language, in a way that they would understand, because they're similar people, right? This is what we've learned over and over and over again, that people don't trust experts. It's not a matter of using logic to convince. It's a matter of getting the right words out of the mouths of the right people, and those are usually their neighbors. And I think there is going to be some kind of U.S. public health workforce, probably not large enough, but I think that would be great. I think we do need a public health workforce, and maybe we won't need it all the time, but I think we're going to need it for a while. And there's so many good things about it. If you start training a U.S. public health workforce, first you'd have much better penetration into the community, and you could do both contact tracing and vaccination, I think, much more effectively. But the other part of it is that you'd give people a job, provide them dignity in a time of tremendous stress. And at the World Bank, what we learned over and over and over again is that if you give poor people money, or if you give out of work people money, they spend it. Whereas if you give tax cuts to the wealthy, they don't necessarily spend it. And so while you're bringing the pandemic under control, while you're increasing vaccinations, while you're giving people a job, you're also providing, what's called fiscal stimulus, meaning if people spend the money, it's good for the economy in many different ways, and not just giving money to the people who would be your public health workers.
How about the role of pediatricians and the pediatric healthcare delivery system? How should we be more involved in changing the culture around the pandemic?
Well, I don't know. You guys probably, I'm sure people on this video conference know a lot better than I do, but I think pediatricians can play an extremely important role in every single one of the issues that I mentioned, because you're advocates for the people who have to live in the world that we leave them. Right? And many times I've started off speeches to young people by apologizing to them for the world that we're leaving them. I mean, the world that we're leaving them is a mess, and the prevalence of magical thinking around using fossil fuels, the magical thinking around the need to prepare for pandemics. We're leaving them a very, very what's the right word? Disorganized and dangerous world. And so, as advocates of children, I think you should feel confident in tackling issues that may not normally appear, in your pediatric, in the training that you receive as a pediatrician, because those are the issues that will affect the children that you take care of as they become adults. I can tell you, my 11-year-old's been he every time I get on a plane, he's angry with me because he says, you're contributing to greenhouse gas emissions, and come on, Dad, I'm gonna have to live in the world of 2100. This is not fair that you're leaving this kind of world for us.
So switching to climate change, what would you recommend as a starting place for us in healthcare to tackle the growing climate change problem?
Well, I think that first and foremost, you just have to arm yourselves with knowledge. There's not. I think what Bill says and Bill Gates says in his book, and it's really true, is that things like taking fewer showers or turning down the heat, those are real. You should do that. I mean, not necessarily take fewer showers, but turning down the heat, being really careful about how much what your global footprint looks like. These are all important things just as a matter of practice. But those are not the things that are going to really make a big difference. I mean, the areas that we have to look at are everything from what we eat. I mean, meat consumption, is just a huge part of the greenhouse gas emissions, and the way that we provide energy to ourselves to for everything we do. Electricity is great, and having electric cars is great, but if you put electricity in your car through electricity that was generated by burning coal, which is still the case in a lot of parts of the United States, you haven't really done a lot. And so I think every single person in the world has to become as knowledgeable as possible on the climate change issue. And then, as a respected professional, an advocate for children, to speak out and find the way that you want to engage. There's no specific way to engage. I mean, the way I'm engaging is I'm now, my full-time job is to build infrastructure, sustainable infrastructure in developing countries. And so it's focusing on the many kinds of clean energy that we want to put in place to be able to provide electricity for people in developing countries. And developing countries, there's still the problem. There's nowhere near enough electricity to give them an opportunity to engage in the economy of today and the future. So there's a lot to be done, and everyone will have to find their own way. But I think start by informing yourself.
Great. Switching gears a little bit, can you talk a little bit about your experience with cross-sector work to advance the health of kids at the population level and sustain the gains? What models should we be learning from?
Yeah, collaboration is really, really important, and it's hard. And I've been a kind of student of collaboration in the sense that being able to work across disciplinary boundaries. I mean, I myself was trained in two very different fields, in medicine and in anthropology. and using sort of putting my anthropologist hat on, talking across disciplinary boundaries is really, really difficult. And it requires persistence and understanding and lots of humility. And so I think, first of all, you shouldn't take for granted that if you just put people together, they will collaborate. It often doesn't happen. And when I was president of Dartmouth, one of the lessons I was taught is, departments, investigators won't collaborate unless you make money available, but only if they collaborate. And then, magical things can happen. I think the evidence for bringing many different views to the table is overwhelming. And if I could recommend another book, I mean, this was something my brother sent me, but also was on Bill Gates's list of top 5 books of the year, is a book called Range by David Epstein. And he writes about the importance of having different perspectives, about having a diversity of experiences yourself when you, as you're growing up, in order to be able to make the biggest contribution. And certainly, I have now, as I've counted the other day, and this is the 6th completely different profession that I've taken on in the course of my career. Now I'm doing infrastructure, investing and building, and it's even very different from what I did at the World Bank Group. And I had to go back and really learn a lot of very fundamental basic things, as if I was learning a new language. And so for me, the discipline and the what's the right word, the humbling nature of learning something from scratch has been really helpful for me, and also helpful in allowing me to bring the diversity of my experiences to the table. One of the reasons they brought me in to run this fund was because of the diversity of my experiences. But one of the things I learned is that I had to make a huge commitment to learning their language. And a lot of it was finance, some of it was energy, some of it was telecommunications. I had to learn their language first to be able to make the contribution. So collaboration is extremely difficult, because people come in with their own languages, and if they refuse to learn the other's language, the collaboration doesn't go very well. But if you allow yourself to go through this process of learning each other's language, then the outcomes are, I think, far more powerful than if you didn't collaborate. And in that book, Range, Epstein gives very specific examples about how groups that had everyone from the same discipline, and in other groups that had people from multiple disciplines, would tackle the same problem. And he argues that again and again and again, those groups that come from varied backgrounds did much better in solving the problem than the groups that came from the same background, especially if it was a complicated multi-sectoral problem.
Specific disciplines you feel like we should be working on to really address the child health issues and crises that we're facing?
Well, I was involved in developing 2 different delivery science programs, one at the Harvard School of Public Health and Harvard Medical School, and the other at Dartmouth. And Dartmouth already had a tremendous tradition of really thinking about delivery issues with the Dartmouth Atlas. And it was a natural for them to start I think it's now a master's program in healthcare delivery science. Healthcare delivery science by its nature forces you to be very broad and deeply interdisciplinary. And so I don't think there's any, I wouldn't recommend any single discipline. But I mean, I think quantitative analysis is really important. I'm an anthropologist, and so I very much believe that qualitative analysis is also can make a great contribution if you're disciplined about it. So as pediatricians, I think I would just encourage everybody to to start reading or even take courses or even do a degree in other fields so that you can get yourself into the practice of learning these new languages. Tina, when I knew you at Brown, if you'll remember, I was monolingual. I spoke one language, that was English. And then when I left, after I left, I first went back and relearned Korean. I came to this country when I was 5 years old, but I'd totally forgotten my Korean. I relearned the Korean language, which is an incredibly humbling experience. 5 years after I finished my dissertation, I learned Spanish. And so again, one of the most humbling experiences you can imagine. When I was in Geneva at the World Health Organization, I tried to learn French. I had made some progress, but learning French was never part of my job there, whereas learning Spanish was part of my job and working in Peru. I've been learning these languages, and now, after that, I had to learn the language of higher ed administration at Dartmouth. I had to learn the language of multilateral development banks, which is totally different language, and now learning the language of finance and infrastructure. So, learning new languages is really good for your brain, but it's also, for me, learning new languages it's the time when I feel most humble, but also most alive.
That's great. So you've talked about the pandemic and the threats of the pandemic, climate change. Another crisis that we are seeing a lot of is the mental health crisis, and was wondering what you feel like we should and can be doing as a leader, as a national leader, as an anchor institution in our community, as a hospital and a system. Thoughts on that?
Yeah, I'm not as up to date as I probably should be on mental health issues, but let me just give you a take on this from our experience in developing countries. So, in developing countries, mental health issues still really are not on the table as much as they should be. And so, when we were doing our treatment programs for drug-resistant tuberculosis, we just experienced a huge amount of depression. And, even some of the medicines that we were giving, just because there had been no new medicines for such a long time, and some of the medicines we had to give, flowed so easily into, through the blood-brain barrier and caused psychotic symptoms even. We had to get serious about mental health care in our project sites. And so in that process, we looked at the different ways that you could provide community-based mental health care, and found that there was actually quite a bit of good experience. One of my colleagues, not now, but former colleagues anyway, Vikram Patel, who's now at Harvard, had developed many very effective community-based mental health programs in India. And so we developed some programs like that for our patients in Peru who are suffering from both drug-resistant tuberculosis and severe mental health issues. But now we've really scaled it up, and now are offering community-based mental health care in many of the communities that we're working in. Of course, at times providing medications. For psychotic patients, we are providing antipsychotic medications in some of the poorest places in the world, and we're doing community-based therapy sessions in some of the most difficult settings. And so I think that again, if we go with just the model of going into a psychologist or psychiatrist's office and sitting and talking about your relationships, et cetera, I think that's going to be less helpful, especially now that there's so many mental health issues in some of the poor countries. That may be great if we could get everybody appointments, and so they could have those sessions. I don't get me wrong, I believe in those sessions. I believe very strongly in the role that individual therapists can play. But I think because COVID has really expanded, I think, the number of people who need mental health services, that this notion of community-based mental health care, where you're speaking with people from your community, you maintain privacy, but having outlets where you can talk about issues and get help and support from others, I think that we've shown that model to work very well in even the poorest communities in the Western Hemisphere, in Haiti, and in some of the poorest countries in Africa.
Great. Another easy question. How do we balance investment in advancing medical technologies and novel therapies that may affect relatively few with public health and basic healthcare measures that affect the many?
Well, I mean, I hope that this stimulus bill will do some of that. It was really important to invest the money that we did invest. And I give the previous administration great credit for having done that so that we are where we are with the vaccines. I think that's been really, really important. And frankly, I don't think it's an either or. I think that it's quite possible to invest, for example, in building a robust public health system in the United States that will address, the issues of poor health outcomes due to inequality, poor health outcomes due to poverty in the United States. I think it's quite affordable to do that, in the context of what we've already spent. So if you look at 1.9 trillion on top of 3 trillion, we're in the $6-7 trillion range in terms of what we've spent just to counter the negative effects of this pandemic. And if you look at that kind of money, spending 50, 100, 200, 300, 500 billion on building the public health response that would bring the pandemic under control, and also at the same time have a lot of strong benefits for the health of poor communities. I think you'd think of that as a bargain, that if it would only cost you a few $100 billion to build a system like that, and that it would help you not have to do this again in a couple of years, because we still haven't learned the lesson of building the public health system that can bring this virus under control. I think you'd think it would be a bargain. And I know that there are really good people in the Congress and in the Senate who understand this and are advocating for that kind of expenditure very aggressively.
So our historian, Kevin Prophet, asks, when the Children's Hospital Research Foundation was founded in 1931, one of its goals was to educate the public on disease prevention, both physical and mental. What are emerging ways to best educate about disease prevention for children?
Well, again, I'm not the expert on this, but again, our experience has been that the best health educators are people from the community, and the notion that you give people living in poverty money to do something like become health workers, it was something that's controversial. So that when I first went to the bank, I couldn't believe how many papers that had been written. It's like 50 plus papers had been written on what we called conditional and unconditional cash transfers, right? And I thought, well, but these are people living in extreme poverty. Isn't the solution for extreme poverty cash, right? And so I asked, why were there so many studies on conditional and unconditional cash transfers? And they said, because people in the bank were so ideologically against giving poor people money. And so it's good in the sense that study after study after study showed that these kinds of cash transfer programs improved health outcomes, improved educational outcomes, improved nutritional status, and also had very positive impacts on the local economy because it acted as fiscal stimulus. So we've had this information over and over and over and over again. And so I think, would PDA, public PSAs, public service announcements help? Sure, I think they could. Would having, athletes and movie stars giving these kinds of information, would it help? Sure. I mean, there's a long history in public health of those kinds of messages having a big impact. The Native American and the anti-smoking, MAD. There were a bunch of PSA campaigns that have had an impact. And so I think you've got to, work with Hollywood and people who are good at making these messages and helping them figure out a way to message. But I just think, the best way of getting a message across is to hear it from your neighbors. And, building now a national public health system focused on the pandemic, and then at the same time, building in those messages, I think that could work very well.
Can you elaborate a little bit more on the public health workforce that you would like to see built?
So, yeah, so we're seeing it at work in Massachusetts. So more than 3,000 were hired in Massachusetts, and they sign a contract that says when they're on, they'll be on. When they're off, they're off. I think the pay was something like $35 an hour, and so it was you had to have language skills. If certain language skills, you had to have the ability to carry out, and it was really contact tracing by phone, because we weren't sending folks out there. But it was a very good wage, and it was extremely important for people who had lost their jobs. And we now have more information on where infections are located and how the disease is transmitted. We have more and better information than any other state in the United States, I think. I mean, I'm not keeping up with every single state and what they have, but we have tons of information on how the virus is being spread, and have been able to be focused about what things to shut down, what things to allow to keep going. And so that kind of workforce could really make a big difference. And again, there are training modules for how you would train folks like that. And I know that the people who've been working in Massachusetts are available and would be ready to help with other states. In fact, I think one of the leaders of our program in Massachusetts is currently working with the state of Ohio, because John Walsh is his name. John Welsh, excuse me, is his name. He's actually from Ohio.
So we talked a lot about the pandemic, and obviously the pandemic of COVID has kind of uncovered structural racism and disparities. What do you think pediatricians, academic health centers, health systems need to be doing to address structural racism and health disparities?
Well, I mean, gosh, Tina, you're only giving me the softball questions. Growing up in Iowa, and just to be clear, Tina grew up in the most liberal, open-minded, urbane place in the entire state, and I lived in the boondocks, relatively speaking. Tina grew up on the outskirts of the University of Iowa, which was and remains, a kind of cultural and political island in Iowa. And I grew up in Muscatine, which was like a working town, just 30 minutes or 30 miles down the road. And so for me, and I'm sure Tina experienced as well, there were very few Asians around at the time. And so I experienced all kinds of racism growing up. Frankly, it was different. My father was a professional. It was very different than what, the Mexican-American migrant workers faced, many of them whom were living in the town that I grew up in. It was very different from not many, but the existing African-American community. I didn't face the same kind of racism, but I grew up knowing that racism is very real. I experienced it throughout my years growing up. And so I think that there's a lot of learning that all pediatricians have to go through. And I remember in teaching a first year class, when I was a professor at Harvard, I taught a first year class in social medicine. And we always talked about unconscious bias and how powerful it is. And of course, there was There are now other studies that have come out that if you ask cardiologists to intervene based on the chest pain story of white men, white women, black men, and black women, there are huge differences in the aggressiveness of the response. The white men got the most aggressive response. The African-American women got the least aggressive response, but also white women there was a clear difference in the aggressiveness of the response, women versus men. So the unconscious bias is very real. And I think it's important for all clinicians, who are seeing diverse patient populations, to get clear about their own bias. I mean, there's no opt-out when you're talking about unconscious bias. For example, if I were to say, hey, I've experienced racism, I'm Asian, therefore I don't have to be careful, or I don't have to go through my own training about unconscious bias. It's just wrong, because I may have unconscious bias about any number of things, including people of other races and ethnicities and other genders, and it's something that you have to be really, really humble about. And I also think that pediatricians in seeing children, one should have great humility about trying to ensure that you do not inadvertently bring your biases into the clinic.
So we've covered a lot of ground. We're charting our next century for Cincinnati children. So, what do you think is the unique contribution that Cincinnati children can make to scientific and healthcare delivery innovations in the future?
Well, I looked this up and I learned that Cincinnati Children's, I think, is the #3 children's hospital in terms of research grants from NIH. Is that right? Maybe I got that wrong. So I think continue to do basic science and clinical research at that level or more. I mean, I personally am a huge believer in the academic hospital world of the United States. We've always said that at Partners in Health that Partners in Health survived to a great extent because the Brigham and Women's Hospital, and then others in Massachusetts, including Mass General and Beth Israel and others, they supported the work of Partners in Health. So while at the same time, there are these incredibly important centers of excellence around basic science, clinical care, clinical research, basic science research. There's lots of other things that you could possibly do. But if there was one thing I would ask, so continue to do the research. The great teaching hospitals of the United States are really the crown jewel, I think, in all of the institutions that exist in the United States. There's nothing else like them. I've been all over the world, and there truly is nothing else like the academic medical centers in the United States. So just keep doing that. But I can't help but think that Cincinnati could be the leader in the world on building the science of pediatric delivery. And I don't think it's just pediatric delivery. I think it's delivery as a whole. And it's everything from, how you train your physicians, to how you organize your clinical services, to, to how you continuously monitor, the quality of your interventions, how you use things like coaching. I mean, if you haven't read Atul Gawande's great piece in the New Yorker about how he got a coach, and he improved his surgical outcomes by having a coach. If you haven't read that, you should read it. It's really important. It's why I've always, had a coach in just about everything I've ever done, for the past 15 years. There are just so many ways that you could improve delivery. And I think the other thing is, I'm sure you, and I've heard that you have a lot of community-based programs, but the outreach into the community is maybe something that could alter outcomes in ways that are much more dramatic than what you do if you wait for them to come to the hospital. And so, there are lots of great models for how you can improve community outreach. And if you link, if you think about community outreach as sort of just your charitable activities, I think you're missing an opportunity. If you think about your community outreach as part of the development of the science of delivery, then I think you're onto something. I mean, we've shown years ago in Boston that having community health workers work with people living with HIV in the area around the Brigham and Women's Hospital, that we could dramatically improve outcomes and lower costs. Right? We showed that over and over and over again, but then it's only grown a tiny bit, this sort of community outreach as a way of improving outcomes. I think you could do all kinds of studies, and maybe you already are. You could do all kinds of studies that would be, I think, very interesting. And then you have to have a chairman of the department who will recognize that kind of research and promote people based on that kind of research, as opposed to just basic science or clinical science.
Well, thank you so much, Jim, for joining us today and for your inspiring words. And thanks everybody for joining today. As a reminder, for those that would like to see credit, you'll get an evaluation today. Please complete it and within 30 days, and it'll be sent to you by email. Really, really appreciate everybody's time and hope it really made people think about where we should be going as a department and Cincinnati Children's for our next century. So thanks.
And if I can say one last thing, thank you very much. I'm very honored to be the first speaker on this series. And I just want everyone in the Cincinnati Children's Hospital community to know that you are very, very lucky to have Dr. Tina Cheng run the department. She was a better student than I was at Brown. She's a better doctor than I ever was. And I'm sure she'll do great things there.
I'll pay you later. Thank you.
Thank you. Thanks, everybody. Stay safe and best of luck.